OPID, so if you don't remember your OPID, you'll need to email me because I have it. But also you will get an email from Ohio Health telling you what to do and what you have to complete before you can be at clinical. So you won't get that yet because I'm sending the spreadsheet in this week, either today or tomorrow probably. And when I send that in, it takes them a while to activate all of you, but then they send out emails now to you, and it gives you directions. There's posted on your course under modules an OPID activation or registration, I think it's titled. Underneath there's a student manual. Follow those directions in the student manual if you get lost. Like, what am I supposed to do here? Follow that manual and it will get you through the classes that you have to take, and it will get you through so that you're activated to be a student at the facility, okay? But if you forget your email, just email me and I'll send it to you. Because you'll have to get in with your email and your open your password email. Open and your password, okay? All right, let's move on. We got about halfway through, so I have to fly through some of these, but some more factors that influence our communication is your physical, like if you've worked 2 shifts, it's your 3rd shift in a row, you've worked 3 12s, you're tired, okay? So what's your physical state as a nurse? That will influence your communication, because if you're really tired, it's like, I'm just gonna get done what I have to get done, and then you're gonna maybe sit in the break room a lot that 3rd shift or something, so that influences communication. Physically, your mental state, I mean, your brain's tired, you're tired, all of those things, but cognitively, emotionally, maybe you got some bad news and you still have to work, and it's maybe your own physical health that's, or you're not doing well and you still have to work, okay, that will affect your communication with your staff members, with your patients, with their family, with everybody. And then what do you value? Do you value being an advocate for the patient? Because if you value that, you'll be that. But it's also, how do you see yourself? Do you just see yourself as somebody who comes to work and goes home, you don't get involved in anything? What do you value in your life? Okay, that plays a part in your interactions with people. And also the environment, we've talked about that a lot. It will influence if it's calming, if it's quiet, if it's not disrupted, you will have better communication. That affects your communication. One way that I can communicate with you is, you guys don't know that much about me, so I throw these slides in here so you get to know me a little bit. So this is my husband. I've been married 33 years, going on 34 now. He works at McDaniel Toyota here in town, so after you graduate and you can make some money, go buy a car from him, because by then maybe they'll have some, because with this whole pandemic there's not very many cars. So he works there. He likes to play video games, and he likes HeroClix, if you know what that is, and he likes to read, but his birthday is May 17th. So whose birthday is closest to May 17th?
May 20th.
May 20th. Anybody closer?
My son's is not actually on the 17th.
He doesn't count. So before you leave today, these have about the same thing in them. I just couldn't get the same size. So take a gift when you leave today. Okay. All right, so here's our types of relationships. So we talked about how to communicate, but then how do we build a relationship? How do we, and what type of relationship do we want to build? We want to build a therapeutic relationship. And we do that by focusing on the patient's needs, focusing on what they're feeling, what they're experiencing, using our communication skills. So if you look at this, a therapeutic relationship is the patient is really doing the work. Okay, they're in the hospital, they have type 2 diabetes. Their goal is to not only go home, but their goal is to have a better diet, because they need to lose weight. So their goal is to lose weight. And we're going to help them, but they They have to be the one who drives that. If they don't want to lose weight, you can make a great plan. But if they don't want to do it, that's why you have to have the patient involved. So a therapeutic relationship says that the patient does the work and you are the facilitator. You help them, you plan, you make goals with them, and you help them to implement it while they're in the hospital. And that they can take it home, you do teaching with them. So as a therapeutic relationship, you can either hinder or help that relationship. So think about it that way. How can I help? How can I not hamper and affect my relationship with this patient? That's your job. So some other components of that are, you want to develop your communication skills. You want to build trust, and you have to do it very quickly. But most of the time, most patients accept you because you're a nurse, and they know what that means. You're here to help. So that's what you want to do with them. So you gain trust, and you do that very quickly. You let them know this is a very safe space. You do that by communicating it non-verbally and verbally. And you want to be able to make sure that what you say matches up with what you're doing. That's the congruence here. So if you tell a patient, I'll, as soon as I'm finished here, I'll go get that strawberry ice cream that you wanted, and I'll be right back. And you don't go get the strawberry ice cream you forgot because you got busy, somebody called you in the hallway. It happens. But then it's too late and the patient doesn't want it. So there was not congruence with what you said you were gonna do and what you did. And the patient doesn't want to hear all the excuses, they just want the ice cream, okay? So if you get waylaid, you might have to ask one of your PCAs, could you go get Mrs. So-and-so some ice cream and take it to her right now? Because you will get busy, but you want to do what you say you're gonna do. That's what happens in households with kids. You tell your kid, if you don't stop that, you're gonna not be allowed to watch television for, whatever. And then we don't follow through with it. Our kids get away with it, so they keep doing it. And then we wonder why. Because we're not congruent with what we say we're gonna do. That's really a very important piece of a therapeutic relationship. You want to show genuine interest. Don't, don't be all fake. Just be genuine with them. Be aware of their strengths and your limitations. You can only do so much. And if you're honest with them, they're more likely to respond to you. So you give them genuine interest, you do empathy, we talked about that, putting the nurse, putting yourself in their shoes. And we accept them. I talked about no judgments. We don't set boundaries, we do set boundaries, not set boundaries. We set boundaries because sometimes our patients will do just what our kids will do. They'll get away with things or try to get away with things. And we don't want them to do that if they're gonna hurt themselves. So make sure you set boundaries. Like I said, set that goal, and they had to walk by 4 p.m. or 3 p.m. That's setting a boundary. It's the same thing we do with you guys. Homework is due on such and such a time. That's your boundary. You go past that, there's a consequence, right? Same thing with patients when you're building a therapeutic relationship. Positive regard. Unconditional, non-judgmental attitude. If you have that, you're going to go a long way in nursing and in everything. Now, your book does talk about the therapeutic relationship as a helping relationship. It's the same thing. I'm just used to therapeutic. So I put that in there just so you wouldn't think I was talking about something that's not in your book. The person that developed the stages of a therapeutic nurse-patient relationship is Hildegard Peplau. Okay, you're going to want to remember her name, Hildegard Peplau, and she came up with these phases, the 3 phases: orientation, the working phase, and the termination phase. You need to know these phases and what you do in them. Hint, hint. Okay? And actually, you could say that there's a pre-orientation phase. What might be in a pre-orientation phase if you are trying to get information about your patient? Before you get oriented to your patient, what are you guys gonna do? You're gonna look in the patient record to find information. So that's kind of pre-orientation. You know a little bit about them, because if somebody did a really good assessment, you can learn about their social history, their family history, and you can learn things about your patient before you ever meet them. But once you meet them, that's called the orientation phase. You go in, you meet them, you establish, because you say, hello, my name is Kathy, and I'm going to be your nurse today. I established the role. I'm the nurse, not the physical therapist, I'm the nurse. So I told them what my role is in orientation. Why am I there? What are we gonna do? We're gonna come up with a plan, okay? We establish the roles, but then we let the patient direct the goals, not roles, but the goals, okay? Hope that's coming out clear. And then sometimes you do have, I want you to be aware that things overlap a little because you're moving then to the next phase. So you do these things in orientation, identify your patient, identify the problem. If you had to make a contract, like many times we have to do that with mental health patients, especially if they're suicidal, we make a contract in the orientation phase. All right, then we go to, I'm gonna skip that, to the working phase. The working phase is then where we identify what the problem is. So you guys are gonna start creating care plans or concept maps. I'm not sure what they're doing. Are they doing care plans, Angie? Yeah, okay. So in your care plan, this is where you're gonna, the problem's gonna be identified, and then we exploit, meaning that we pull it out, make it usable, make it measurable, understandable. And we ID the problem, and then we determine what skills do we need, what does the patient need. And this is a really important phase where you have to interact with the patient. In the old days, because I'm an old nurse, we just would go out and create the plan and do it. Now it's more, especially in mental health, not always on med-surg, because you guys will have, like if you're on a post-op floor, then you have like patients who've had knee surgery, they have to follow this pathway, like so many hours after surgery, they get up and walk, and they get on the CPM, and they do this and this and this on this day. You do that a lot. But sometimes there are other things that you will have to work with the patient on, that you have to come up with the plan with them. So sometimes it gets convoluted, but the working phase is actually where they do the work. It makes sense, right? So if you're supposed to get up with PT 3 times a day, that's what we're gonna do. We're gonna work it so that you can get that knee back in shape before you leave. All right, and then we move to the termination phase. We always think discharge when a person comes into the hospital, because you have to, they're in so short anymore, you have to think about, okay, within these 2 days that they're in the hospital, which is maybe all I get, I have to think about, okay, when they're going home, the social worker I gotta work with, because they have stairs in their house. So do they, things like that, we have to start thinking about when they are admitted, we have to think discharge. But termination is different than discharge. It's a part of it, because when your patient goes home, obviously you've terminated the relationship, right? That's part of it. So when the patient leaves, and then the relationship is ended. Sometimes the patient's still in the hospital, but maybe you don't have that patient the next night. It's not always a good thing, because you can get continuity or consistency to have the same patients 2 nights in a row. But if you didn't, you're still in the hospital and the patient didn't go home. Your relationship with working the plan is now different, because you're not the nurse working with the patient. So you've really terminated that relationship, even though the patient's still in the hospital, right? But definitely when they go home, you terminate. And we usually only have our first name on our badges. You might have a letter at the, like Kathy C. But we don't put a lot of information on our badges because we don't want patients contacting us after their discharge. It happens, especially with mental health. We don't do that because they will seek you out. So we don't want them to be able to look you up in the phone book or on Facebook or anything like that. So that's why we don't really want to you don't want to give out your last name, and you don't want to give a lot of information about yourself to your patients. All right, so they're terminated, they're discharged, and our relationship is over. So there's a couple more things with therapeutic now. We've built a relationship. We know what verbal and nonverbal communication with our patient is. But there's another piece to therapeutic communication, and that's called active listening or empathic listening. And that's where you really are just honed in on what the patient's saying. Now this comes to your part of being therapeutic. Because active listening is maintaining eye contact, not just staring at the person. I mean, you'll look away, but you'll look back at them. It might be nodding your head. You understand what they're saying. They know that you're listening to them. When they see nonverbals like tapping your pencil, it's like hurry up, or I'm not sure exactly what that's saying to them, or maybe it might be shaking your leg, and you might do that just a part of who you are. But think about what it's saying to your patient. She really wants to get out of here, I think. Or she's nervous. She's nervous. Okay? So you have to just sit there and actively listen to them. Be very aware of your nonverbals at this time. And then active observations, watching their nonverbals so that we can speak to the patient and speak into the things that they're talking about when we actively observe them. I'm skipping these questions because we don't have a lot of time. So this is my daughter, and she married Chris Leinbach. Chris Leinbach is a math teacher here at Marion Tech. So that's my son-in-law. I see the faces. Hey, I didn't know that. And I have a grandpa, Archie, and he's a Bernedoodle. So my daughter is a licensed social worker, and that's what she loves to do. So their anniversary is December 30th. We'll be married 4 years this year. So who has a birthday close to December 30th? What do you have?
December 30th.
December 30th. Well, you get the prize then. We don't even have to talk any farther. Don't you love December birthdays? I got a December birthday. I don't like it. I get birthday presents with Christmas presents. You know how it goes. Yeah. Okay, come on. We'll go to the next one. Okay. Yeah.
You know you have till 12:15, right?
Yeah.
Okay.
Yeah, I do. I know I had another hour,
Okay.
but I just had a little more than half of my slides to go. All right, so professional communication skills. So now think, well, you're in a profession, right? So how do we professionally speak as well? These are just things I pulled out of your book. Think about it this way. Are there areas on here that you can improve upon? So can you improve upon your conversation skills? Like when you walk into a room, do you have something in your mind you can talk about with the patient? Just to, make it easier, help you to calm down. A lot of times if you can ask patients, where do you work? Or if they're retired, say, well, what was your job as retired? If you go that route, that gives you something to talk about. So you want to have conversations so that you can build trust with your patients. And, it helps you to be able to just have a conversation and get them talking. Because you may need some more information. Okay? Sometimes though, don't overdo it and just talk. Remember, we want to even that out. Our conversation skills, though, should be clear and concise, like we've already talked about, and open-minded. What if your patient says that they're transgender and you don't believe that way? You know, you can't be like, oh, okay, I wonder what parts they, you know, your mind's going somewhere. Nope, just stay there and just accept them for who they are and have an open mind to it, because that's who we are as nurses, okay? We have to be non-judgmental. So we want to listen. Some of us can improve our listening skills because we want to actively listen, like I just talked about. You want to, when you're listening to a patient, though, listen for themes. If they're talkers, what are they mostly talking about? Are they talking about their family? Are they talking about themselves? Are they talking about their culture? Or are they talking about something else? So you can pick up themes when patients are talking, especially when you're doing things like if you have to give your patient a bath. And that can be somewhat invasive. Your patient might be more comfortable to talk while you're doing that. Or you might feel more comfortable to talk. So, you know, just listen for themes when people talk a lot. Silence, once again, you gotta be okay with it. When we, like yesterday, took a test and it's really quiet in here, some of us, that makes us more anxious. And if you were with someone one-on-one and it was just quiet, are you okay with that? When you drive in the car with your spouse or your kids, is it just quiet the whole time? What if it was? Are you okay with that? You gotta get okay with that. Yeah, I like quiet. Okay? But when we excessively talk as nurses, guess where the focus goes? On us. That's why you want to be careful about how much you talk. Because if you talk a lot, eventually you're talking about yourself. And that's not what we want the focus to be. So pull yourself back so you let the patient talk, all right? Your use of touch, it has to be professional. We've talked about that. Humor. Humor can always break the ice. You got a dad joke? Give it to them, you know. They're bad, but give it to them. But you can laugh at yourself. You make sure the patient knows that, and hopefully the patient is okay with themselves. But when you have humor be a part of it, it usually breaks down anxiety. It's like, okay, she's all right. She'll be all right as an instructor. She made me laugh, and she, you know, I like that. So humor can do a lot. When you interview somebody, here's some techniques to use. So look at this picture here. What do you see when you look at that picture? Hope I'm not in you guys' way. What do you see? The patient's laying down flat, okay? Which is kind of odd, isn't it? Because usually we at least have the head up, huh? Okay, what else?
The wife is probably saying, explaining.
The wife, if that is her husband. So we don't know whether the patient, are they sleeping? Is he comatose? Why is he not engaged in the conversation, right? And she's talking over the patient to, and this looks like the nurse, right, or the student nurse. Looks like a student nurse to me, I don't know why, but it does. Okay, they've got paper, it looks like, or a brochure. What else do you notice? What's that? Alignment is out of alignment, you think? Okay.
He's on the same level though.
Okay, they're all sitting. I mean, there's the two are sitting that are talking, and they're like eye contact. That's good. It is a small space. Do you see culture?
Yes.
Okay. And it looks like they might all be the same culture, which is good, I think, to have a good conversation, right? So when you're interviewing someone, this is why, if we went back to, let's say that's Randall in the bed. Remember Randall at the beginning when we started today? Middle-aged man. Now, he doesn't have all the tubes and everything, so maybe he's on hospice now. But let's pretend that that's Randall. And let's say that they're discussing DNR status, which is do not resuscitate. So if this patient stops breathing, you're not going to do CPR, you're going to let them go. Okay, do not resuscitate. So let's say they're talking about that. Is this a good conversation to have in the room?
No,
Why?
the patient is there,
The patient is there,
the mental effect.
okay? What if she's his wife and they've already discussed what they want to do though? Like when it comes to end of life. He can still hear, more than likely.
Yes.
But you know what he's gonna hear? He's gonna hear that his wife's okay with it. His wife is following his wishes. His wife is doing what he wanted, okay? And he can hear, yes, probably the sadness in her voice, that she has to let him go. But this is a really good conversation. If they've had that before, it's very difficult to have that conversation, but in this case, they are not closed. They are open. That's non-verbally letting us know that. She knows that if he has something to write down that's important, he's going to write it down. So I think she's going to take him seriously, right? So we can get a lot of things just from looking at this. Open, we want to ask open-ended questions. So open-ended questions means it is not a yes or no answer. Lots of times those are the questions we ask. Do you want to take your bath? Do you want to eat now? Okay, it's yes or no. Those are closed-ended statements because the only answer is yes or no. Now sometimes patients elaborated on it, but it's still a yes or no. We want to ask open-ended. Tell me what you're thinking about DNR. Tell me, did you and your, tell me when you and your husband discussed this. You know, because then we find out, well, it was years ago or something like that. So open-ended questions. We want to validate what they're saying. See, he's validating that it's important because he's on her level. He's going to write it down. He's validating what she's saying. He's looking at her. He's got good eye contact. That's a validation. All right, clarifying if he needed to, you know, say, restate and see if that's what she really meant when she said that. And before he takes it, because you have to get an order from the doctor for it, before they take that to the doctor, he wants to make sure exactly what she wants. So she might need to clarify it, might need to reflect and repeat things, and be very direct, you know. Sequencing is not necessarily in this case, but, you know, when things happened. So we got to put them in order. We want the patient to tell us that. And be very direct in our professional communication skills. So you can be one of two things when you need information. To be professional, we want to be assertive. Or we are going to be aggressive. So many times this aggressiveness might come out when you guys have a test and you don't like the questions that were asked, or you think that one was right and we said that that's not correct, and you get kind of upset about it, and students come to us and, you know, they've gotten loud. That's how it looks, okay? When somebody is assertive, that means you keep it in the I arena. It doesn't mean that you're not upset. It just means that you say things like, I studied this, or I thought that what you said in lecture was this. So you keep it in the I arena, and it comes off more as you really do want to understand, but you have to be assertive in that. So you have to sometimes go in and be assertive that you're going to stand up for your patient when, nobody else will. And you say things like, I believe that they need home health. I believe that they're going to need advanced services when they go home. That's being assertive. You go talk to the social worker, you talk to the physician. But being aggressive is a lot of anger comes out, raise your voice, you get in people's space, and it's sometimes rude, it sometimes comes off as not professional. So you want to be assertive, you don't want to be aggressive. Even when you really need to stand up for something, still be assertive. And yes, your voice may get louder because that's what you believe in. I kind of go there with politics right now, and I want people to hear my side, but I need to be assertive with it and not aggressive with it, okay? Because they still need to hear other people's points of view. So, I have some questions at the end, so we'll make sure we have time for them. So here's some blocks to communication. So we talked about ineffective communication, but what are barriers to having communication? Perception is a barrier. You want to have positive outcomes when you're communicating with somebody. You want to improve your own job satisfaction. This is how you want to communicate. So stay away from these things that'll block your communication. What does the patient perceive of me? Okay? Don't just look at the patient as an illness. Like, okay, I'm taking care of Mrs. Smith in 42B. She has COPD. And when you see your patient, you just see COPD when you walk in. You're not seeing the person as a whole. All right? Don't be distracted by a medical diagnosis or a dysfunction. We could go back to our Randolph in the bed. What do you think he perceived? And we don't know because he's comatose. So we want it to be even a keel. We don't want to just go in and work on the tubes and never talk to Randolph. You want to tell him what you're doing. Especially batteries went dead. Love that. They don't even have 2 batteries charged in there, so we're just gonna not have it. I can talk loud enough. You can hear me back there, can't you? The last row? Okay, that's good. All right, so there's a block to communication, all right? It's right there. Came at the right time. Okay, so if we go back to Randolph, though, and we talk about the perception, really it's going to come off like, what's the perception of the family think of us? Because Randolph can't tell us. But we want to come off with have that be a block to our communication. Another block is failure to listen, okay? Sometimes patients can very subtly tell you that they want to talk to you. And they may never say those words, but you want to be able to pick up on that so that you sit down and have a conversation with them. So it just might be that maybe you saw them start to cry. I think that would be an indication that something, maybe they can't talk about it. Maybe they just need you to sit with them. But if you don't pick up on that, then that's a block to communication because you have a failure to listen potentially, okay? So that's just an example. It could be other things. Changing the subject. Now, that's different than trying to get them to focus. But changing the subject, sometimes you just talk and talk and talk and the subject keeps changing. I don't know that that's a really professional therapeutic communication. Now, you might do that at home, but you're not really trying to be professional at home, maybe. All right, so there's a place for it. False reassurance or false assurance. This could really indicate, you know, when people say, it's gonna be okay, honey. It's gonna be all right. First of all, don't use honey. And second of all, you don't know that it's going to be all right. Now, if you do and you can reassure them, then okay. Because a lot of times, like, people get nervous about getting an IV. And if you've had an IV, which I have, I know if it hurts, it's gonna hurt for a little period of time. Then it'll go away. I can reassure them of that. But if they would get a diagnosis and it's life-threatening, you can't assure them that everything's gonna be okay. So that can look to the patient like you don't really care about them because you're not being honest with them. I know we want to because that nurturing, especially us females, that nurturing part comes out and it's gonna be okay. We're gonna be all right. Now, we're gonna be all right, I don't know that. All right, so be careful what you say, that can be a block. And then gossip and rumors. Yeah, they cause blocks. Go back to our clinical group scenario that we did. If you're gossiping about another student in that clinical group, or you're gossiping about another instructor, it's not your instructor, or you're gossiping about, I don't know, something you saw on Facebook, whatever. It's a rumor. Rumor mill gets going with you guys in nursing courses too, I know that, because like the class that's ahead of you tells you things about this, and a lot of times they're not true, so it's gossip. Because nobody comes and asks us, the professors or the course coordinators, what's the truth? You just pass it on from class to class. And we know it happens, we just know it happens. But that's a block in communication when you're gossiping or spreading rumors around. And if you're doing it about patients, just because you know them, you know, I used to do clinical at Morrow County Hospital, small hospital in Cardington, or Mount Gilead, actually. And I knew school teachers that my kids had that were patients in the hospital when I had students there, okay? If I could avoid that, I didn't assign my student to those patients because I didn't need to be looking in their chart. Now, if I did, and we saw that, then that stayed there. I didn't go home and tell my husband all about so-and-so was in the hospital, was, you know, my son's 10th grade teacher or whatever. That's not what you do, okay? We don't spread things around like that. And that's HIPAA, that's confidentiality. It's hard in a small town, but you can do it. Some more blocks are using, and these are non-therapeutic. Not that cartoon up there. They dropped the patient on the floor. Can you see that? That's why we lift on 3. That's good communication. You're all working together, all right? So try not to use cliches. These are things that should be avoided. Cliches, sometimes we have things that we say in whether it's American, whether it's in our own family, but we say things and other people don't understand what that means. So if you're using things like that, that can be a block in your communication because they may not be assertive and say, I don't understand what you're saying, or I don't understand what you're laughing at. They may not say that because, and then they get a perception. So try not to use cliches. Try yes or no. Only if that's what you want. Like if you're doing an assessment or taking a history, you might want yes and no, because you know when you go to the doctor and you have to, have you ever had cancer? Yes or no? Do you have, those are yes or no. So we do have to ask those sometimes, but we're only trying to get a history. This is the one we're talking about doing things outside of that for our patient. So if you ask yes or no questions, you've cut off the communication. Try to start conversations with tell me. that opens it up. Tell me about your, tell me what's normal for you to eat in a day if you're working on diet. Tell me what you eat at breakfast and lunch and dinner. What's a typical day? Don't start conversations with why. Why are you going to that doctor? Or some, because that puts people on the defensive when you start with why. All you have to do is tell me in front of that. Tell me why you're having trouble with your diet. Now, doesn't that sound better? Then why are you not eating correctly? See, doesn't that put you on the defensive? The hairs on the back of your neck go up. And if I say, tell me what you ate yesterday, that's much better. Okay, so yes or no stops conversations. Tell me, asking open statements helps to not cut it off. How or why? I just told you that. Don't start conversations that way. And you're gonna see it in test questions. You need to throw those answers out if you remember. Because starting a response with why puts people on the defensive, and how. So be careful about looking at answers like that on tests, because I will give you communication questions. Blocks to communication also are probing. You gotta follow the patient's lead. Sometimes that's more information than we need to know, so I don't need to ask those questions. Leading. If you are trying to, this is more what they would do in a courtroom. So we don't want to do this with our patients. We don't want to use leading questions because we're trying to get an answer. We want them to talk to us. Try not to use advice. You know what advice is implying to your patient? That you know better than they do. Okay, don't use advice. Well, this is what I did with my child, because they think that you know more than they do. It'll block communication, and don't be judgmental. We've talked about having a non-judgmental attitude. So some other blocks are being disruptive. It can be ineffective, abusive, negative. So go back and think about code of conduct. We'll get into, especially when we get into mental health, incivility and civility, covert and overt. So make sure you know those words, what they mean. Why would I use that? Because we start getting into areas in mental health when, okay, do they have a right? And that may not come yet for a while because you guys aren't going to be doing mental health, but that'll be coming. Those are some blocks to communication that do not help us to help our patients. So what are some responses? Try to promote a healthy environment to work in. We all want that, don't we? When we go to work, we want to go to work because we want to go to work. And sometimes we have to go to work because we do need money. But we can either make it a good atmosphere or a bad atmosphere. So we don't want to block communication by giving negative responses. We want to remember that we have the ANA Code of Ethics that we have as nurses. This is what that states. It states that we as nurses will have an ethical, moral, and legal responsibility to create a healthy and a safe work environment for nurses and all members of the healthcare team, healthcare customers, families, and communities. So when you get your nursing license, that's your code of conduct from the American Nurses Association. That's why I say we can't really be judgmental people, because we're taking that oath that we won't. All right? All right, I have some other questions at the end. All right, here's my last one. This is my son Jordan. He married Emily and they live in Holland, Michigan. They also have a Bernie Doodle, but he is 85 pounds. He's like this big. He's huge. His name's Odin. And my daughter-in-law is a speech pathologist. My son is a worship leader. and he writes songs, and he's a musician. So their anniversary is August 18th. Who has a birthday close to that? Anybody have a birthday in August? When? The 11th. Anybody closer? You can pick up one of these when you go, okay? All right, now you know my family. That's it. Until grandkids, I just have grandpups. All right, so we're gonna go back and finish out today with Randolph again. And remember up there, that's who he is. So we're gonna look at what outcome do you think that we could have for him visually? Is there an outcome? He's comatose, right? So visually, he's not going to, okay? This particular patient. Now, that's not true of every patient, all right? So let's say that you're gonna walk into, let's kind of put it in context here. We're gonna give Randolph his IV medication. So we're walking in the room to give this IV medication. And so, how do you see yourself communicating that to Randolph?
Start by touch and saying who you are and open the conversation like he's listening.
Okay, so why would we not do it the same way we do with every other one, right? So we walk in, I would get close enough that he can hear me, and that don't have my back to him or anything like that, because he can't see me. And I introduce myself, I wash my hands, I'm gonna tell him I need to look at your ID bracelet and match it up with the chart, or the MAR, and then I have this medication I'm gonna give you. Now you're not gonna feel it, Randolph, because I'm gonna put it into the tube that's in your arm. So you just tell him everything, okay? Because he cannot see. And so that's our behavior. You treat him the same you would treat every other patient, right? Okay. So observation and perception. I don't know what his perception is, but I don't want his perception to be any different than any other patient I would care for. And so if I treat him the same way, it won't be. Okay, he can't see me smile, but doesn't mean I don't smile. All right, he's gonna hear the inflection in my voice or how I talk. So that goes back to our tone, how loud, how fast or slow we talk. Are we talking to him or at him? All of those things make a difference for the perception. So auditory, hearing. So this is going to be his number one way, is auditory and touch, kinesthetic. So he's going to hear what I tell every other patient, hopefully, and hopefully he'll be able to hear in my voice that I care for him, that I'm not treating him any different than anybody else, all right? So then kinesthetically, we talk about touch, and with him, you have to be more intentional, right? Because when you walk into a room, that patient can see you and respond back to you, they can see that you're going to touch them. Randolph can't see that. So I'm going to tell him before I do that so that it doesn't scare him, right? So in different situations, we have to use that kinesthetic touch differently because of our patient. So I would just say, I'm gonna touch your arm where your IV is in your hand, and I'm going to put the medication in there, so you're gonna feel me touching your hand. I've seen it before, patients, and especially even if patients are asleep, they just go in and do what they do. I get that on night shift, because you don't want to wake a patient up every time, right? Okay, but if it's during the day and they're napping, I don't think it's necessarily inappropriate that you're telling them what you're doing. Okay, so think about where you're at. Okay, and what you're conveying in your talking. So the last thing is self-awareness. So we started today with, do you have good therapeutic communication skills. And probably only a third of you maybe raised your hand. And then when I said, do you do it all the time? The hands went down. So we have room for improvement, but part of how you improve is to be self-aware of what you do. So on there I have, be aware of your nonverbal communications. Be aware if you're smiling or not smiling. Be aware if you, does your nonverbal match your verbal? And if you're not aware of it, it's a good idea to videotape yourself and then watch it. Videotape yourself while you're practicing. You guys all have smartphones and a lot more stuff than I can never think of. But I know. You could, like when you, is the next skill you're doing physical assessment? I'm assuming that, okay. I thought so. So you're gonna have to do a head to toe assessment. Film yourself doing it at home. Use somebody in your family as the patient, do your head to toe assessment and film yourself. Because you will not know what your nonverbals are doing if you don't see yourself. That's how I knew when I started lecturing. I videotaped myself and I watched it, and I don't know how many times I touched my nose. I didn't know it while I was talking. Or have you ever been in a lecture or a conference or something and somebody says, every other, well, that's, just say it. And I can sit there and I start counting the ums instead of paying attention to what they're saying, right? So when you're talking to people, you have to be careful of how you talk. What are you saying? Are you putting in things that don't need, you just videotape yourself. I stopped doing that because I consciously knew that I was doing it. So I would start to and then I'd quit because I knew I was doing it. And eventually it just went away. I don't do it anymore. But if I never did that, I wouldn't know, because who's gonna tell me that? You guys are, right? So be self-aware of that. Also be aware of how you perceive people. If you have a judgmental attitude, you need to try to get rid of that because you're going into nursing. So get rid of the judgmental attitude. You're going to have to work with people who have all kinds of dysfunction and things on their body and things that they say, and we need to be able to be okay with that. Ask for feedback. That's a tough one. While you're at clinical, ask your peers, how do you think I did today? That's really putting it out there, isn't it? Or ask your instructor. Why are you gonna wait for them to tell you? If you be assertive and say, was there something else I could improve upon? Like, they'll go in and watch you do your first head to toe assessment and they'll give you feedback. But then after that, well, did you pass your meds really well? Are you staying busy? Are there other things that if you be assertive and go to your instructor and say, I'd like to know the areas that I need improvement upon, which your clinical evaluation will tell you that, it's on paper. But don't be scared to talk to your instructors. They're there to help. They really are, but they're also there to make you think. So when they ask you questions, it's not they're trying to single you out. You need to take their feedback and then try to make improvements upon it. Like if they say, you didn't really maintain eye contact with your patient, you just might not be aware of it. So don't take it as negative criticism. It's to try to help you to be better, okay? So if you're not aware of what you do or what you're not doing, you can't improve upon it. So that's not a bad thing to self-examination. Okay, I always put some questions at the end just in case we have time, and we do have a little bit of time left. So you're a new nurse assigned to care for a patient admitted to the mental health unit. After hearing the report, the nurse finds that the patient shares a history and background that are similar to the nurse's own experiences. But which action would be most appropriate for her to take or him? Everybody say 4? Why? Conveying a sense of empathy based on shared experiences and using the similarities to build rapport. I thought empathy was, I didn't experience it. That's sympathy. Right? Okay, so if we throw out 4, what's the answer? 2. Answer's 2. Acknowledging that biases may occur because what? We had the same experiences, but they're still different because we're different, right? Okay, so we acknowledge that there's biases and be careful to validate the patient's perceptions. That's the answer. You don't like that answer?
Because it says similar.
Okay.
It says backgrounds that are similar.
But, so that means that I have experienced it, which is sympathy, not empathy. Okay? That's why I put these in here, because we want to talk about it. A child's parent enters the nurse's station yelling, "What is wrong with you people? My daughter cut herself and you allowed it to happen. I thought my child would be safe here." Select the assertive response.
B and D.
B.
Oh, D may not be because of the West.
Okay? So automatically, we're gonna throw out 3, right, or C on there. And why are we gonna do that? Because it started with Y, right? Assertive always starts with I. Okay, so all the other ones could be appropriate. I can't help you right now. The child is assigned to another nurse. That's not right, is it? Okay, so we throw that one out. I can't hear if you're yelling. Let's sit down and talk about it. Or we have, I am sorry this incident happened. We were short-staffed today.
B.
Yeah. Why, I like 2. B. D, why is that one not really the best? Okay, it's an excuse, that's right. We're short-staffed. They don't care. They need the same help. It doesn't matter if you're short-staffed. But we like to use it as an excuse. Okay, one more. Patient says to the nurse, "I dreamed I was stoned. When I woke up, I felt emotionally drained as though I hadn't rested well." Which comment would be appropriate if the nurse seeks clarification? So that's what we're looking for. I heard C. That's what we think. So all in all, you feel as though you had a rather poor night's sleep. That's not clarification. What is that?
Restating.
Restating.
D.
Yeah. The answer is 4 or D. Give me an example of what you mean by stone. Okay? Because what do you think when you hear that? I dreamed I was stoned. Did people actually throw stones at them, or were they drunk? Okay, so that's clarification. Everybody got that? Okay, all right. So it's time to go because the next group is dying to get in. Okay. Good day. Yeah. I always do this thing so they know. So we have a birthday.